corneal reflex. Something gets in your eye. You blink your eyelid. You're trying to tear up to clean that stuff out. If your doctor is checking glaucoma, he comes with that scope and he touches the surface of your eye, then a lot of times people can't help but blink and then you don't get a good glaucoma test. Tympanic reflex, really loud noises that creep up on you. A sudden boom, your brain has no way to fire action potentials fast enough to decrease the amplification by the middle ear. So the sound is actually louder. But if somebody's dialing up their boombox or their stereo and it's progressively getting louder, then your nerves start to fire and they start to impede the vibration of the ossicles, and then transmission goes down. The job of your ossicles is really to amplify sound, but when the sound is getting louder, there's no need for amplification, and actually it can actually do harm to the cochlea. So to prevent the really intense sounds, high amplitude waveforms going into the cochlea and causing damage, you have the motor component of your cranial nerve 8 firing. So remember when we did cranial nerves, I told you sensory nerves are mostly sensory because in the cochlea, you talk about it as a sensory nerve, but here are the motor nerves firing to, well actually those are happening by other cranial nerves, but there's also nerves that are going in from the vestibular, from the auditory component of the vestibular nerve that are inhibiting the vibrations at the cochlear level as well. So tympanic reflex, sorry to confuse you, that actually is middle ear, but there's an additional motor component of cranial nerve 8 that is going to interfere with so it's a motor component of cranial nerve 8 that will impede the vibrations at the cochlear level as well. So next chapter. Auditory reflexes, loud sounds, like me hitting the desk and you looking up. That is controlled by the the inferior colliculi, and so eye and head movements in conjunction with location of loud sound, that's an auditory reflex. Vestibular ocular reflexes. So if you were in lab, they did an experiment where they had a person sit on a chair and then they spun them around, and if they could see the eyes, they're spinning them around. When they start the spinning, the eyes are going to jerk in one direction. When they stop the spinning, the eyes jerk in another direction. So it's based on whether the fluid is bending the receptors in a particular way or not. So when the body starts moving, fluid lags behind, receptors get bent in one direction, depending on the direction of the spin. And then you're spinning to the left, receptors go to the right. Or you spin to the right, they go to the left because of the inertia of the fluid. But when you stop the head moving, the fluid wants to keep on moving. So now when you stop moving, your receptors are bent in the opposite direction from when you started moving. So in other words, your brain is really confused. Am I moving? No. Am I moving? No. Am I moving? No. So your eyes track in the direction that the brain is seeing the fluid distortion of the receptors occurring. So it has a certain map that it's going to have set up already, if the distortion goes in a particular direction, the brain expects the movement to be in that direction. But when it's this start and stop, and it's actually in the opposite direction, your brain says, let your eyes figure out, are you moving? No. Are you moving? No. So you see this nystagmus going back and forth until the fluids stop moving and the eyes stop moving. You have a question?
Yeah. Is that at all bad for your brain? Like,
no. You're not going to die from it. You might get nauseated. So if you're spinning and you're not able to either to override that disturbance, you get motion sickness and you might throw up. But I don't know of anybody who's actually died from motion sickness, but if you're throwing up constantly, yeah, that could be metabolic alkalosis, that could be bad. I don't think you're not going to die from that or get sick too much. Motion sickness, you can survive that. Okay, visceral reflexes mean organ systems. So the viscera of the eye, you have direct light reflex. This is going to cause constriction of that pupil. It is via the optic nerve, but not really via the photoreceptors. They discovered that the photoreceptors find out after pupillary constriction that the light is bright. There are actually ganglion cells that are photosensitive. So they're firing first, the light hasn't even hit the receptors yet, and the efferent pathways are starting your constriction of the pupil. You handle it partly by the superior colliculus, but also by two other nuclei that we'll talk about in the next chapter. And the concentric light reflex is similar to that if you shine light in the right eye, you should get constriction of that pupil and the opposite pupil as well. So shining the light in this eye, if there's no constriction, if you shine it in the right eye and there's no constriction, then there's damage to the ganglion cells. But if that eye is constricting and the left eye is not, then there's a problem in the relay pathway that crosses over in the midbrain to the opposite eye. And that's a sign of syphilis. So we test and we have a good time laughing at people with really dark eyes. You can't tell if they're having a consensual light reflex, so they go, you got syphilis. But no, you just can't see the pupil constricting because the eyes are too dark. Okay, so if you use these diagnostically and you use them also as a protective reflex. This second impact syndrome kind of hit the news. It's been in the news for a couple years, but now with the more prominent football players coming forward with their discussion of how this has affected them, then it's kind of resurged again, had a resurgence again this year. With those professional football players, it's not just second, it's third, fourth, fifth, sixth, seventh, 20th and 30th impact syndrome. So they just get blasted so many times. What occurs is either major brain damage, but sometimes minor brain damage that you sort of recuperate from. But the second time, the inflammation is much worse and could actually ultimately lead to death or some more catastrophic symptoms occurring. The short period of time, hours, to me that's too long. Days, way too long. Weeks, way too long. But they talk about that as a short period of time as opposed to a chronic problem which would persist for the rest of your life. The problem with the second impact is that you get even worse cerebral swelling. Where does swelling go? It only has small openings to get out to where the cranial nerves are, or it's gonna be, the fluid is gonna push the brain down into the foramen magnum. And if you push the brain down into the foramen magnum, then any fluid that's accumulating up there has no place to go, because the veins are getting obstructed, the internal jugular, the vertebral veins are getting obstructed from their flow out, so the pressure just continues to build up. The brain herniating, that means the brain is now getting pushed down through the foramen magnum. And I told you about these tonsillar lobes of the cerebellum. These have a lot to do with motor functions, but those are the first ones to get shoved down into the foramen magnum. And as they get shoved down into the foramen magnum, they compress the medulla oblongata. You got respiratory and cardiovascular centers there. If those get compressed, your heart or your lungs stop, you're away, right? So could be catastrophic results if the brain herniates. Anterograde means forward. You're not able to form new information, new synapses, so you can't store memories. You have experiences, but you don't remember them. So it's referred to as forward grade or antegrade amnesia. So new memories can't be formed. And particularly vulnerable are adolescents who don't have the proper gear. A lot of times the high school football players, they're wearing equipment that's too big for them. Because the school buys big equipment because maybe the students will grow into it, but if they buy it for each individual and the next group that comes up to play, they're not fitting that equipment, then you have to buy new equipment. So they tend to buy oversized equipment and just put smaller players into bigger helmets and shoulder pads. Well, bigger helmets means now your brain is impacting your skull, and then your skull is impacting the helmet, and so you've got multiple reverberation injuries occurring there. So ill-fitting equipment contributes to the brain damage in adolescents, and also adolescents who don't work on this musculature here. You look at professional football players, especially the guys who are doing the tackling, their necks are as wide as their ears practically, and they're just this big stump of muscle there. That gives a lot more support to the head. You have a nice tapered in neck, you don't have as much support when you get impacted. Then the neck is going, then the head is going, the brain is going. And if you got a fitting helmet, that is causing trouble as well. So return to play guidelines, they're getting more strict as the evidence of the damage is starting to mount. Used to be the coach and the player made the call. The player says, yeah, I'll go back in. The coach says, fine, go back in. Now there are protocols that they're trying to put into place. So once you've had a concussion, you're not going to go back into the game until you've been evaluated to the system, whatever that's going to be. Okay. Special senses is the last chapter that we're going to cover. And it actually is more than special senses. It also includes a little bit about general sensation. Not going to go over any of the receptors. They're in the PowerPoint that I posted for you. But we've already covered them because most of them are located in the integumentary system. So you've already gone over them at that point. So we just start out by talking about how receptors respond. They're going to have a particular modality, particular sensation that they're going to respond to the best. So photons of light for your photoreceptors, that's the best stimulus for your rods and cones. But close your eye and press on your eyeball and you see light. Maybe bright yellow, or maybe after a while you see stars floating around that are blue and red. And this is pressure, but it's not light pressure. You have to press pretty hard to get the photoreceptors to respond to that pressure. So the modality is the best stimulus. So for a photoreceptor, it's light. For olfactory receptors, it's chemical. Taste is chemical. For hearing, it's mechanical, vibration. So each receptor has its quote-unquote adequate stimulus. This is a stimulus to which it responds at the lowest stimulus intensity. So for the photons of light, one rod can perceive one photon of light. That's the adequate stimulus, one photon of light for a photoreceptor. Pressure, you're going to have to put a lot of pressure on that eye to get light perceived by the photoreceptors. So what that actually does for your receptors is kind of protect it from being stimulated by things that it's not designed to respond to. So you have to exert a lot of mechanical deformation to the eye to get the eye to perceive light. So normally just blinking your eyes, it doesn't set off your photoreceptor. So a little bit of pressure, no. But a lot of pressure, yeah, you can get the eyes to respond to that. The vibration receptors, they don't respond to light touch. You have to have the appropriate stimulus. Thermoreceptors, they're separated from pain receptors until the heat is really hot. Then all of a sudden you stop perceiving heat and start perceiving pain. So they're protection from one sensor to another, so that the receptors are more specific to the particular modality. For general senses, and also even for special senses, we have receptive fields that are set up. For our skin, the receptive fields can be very small. They can be 1, 2, 3 receptors to one nerve axon. In areas like our lips that are very sensitive, fingertips that are very sensitive. But then you get to the back, and the number of receptors may be huge, hundreds, thousands of receptors in one receptive field, but they're all going to go to one neuron. So it's sort of, you think, well, it's kind of a waste of information. Not really, because you do know that there is a point of contact within this receptive field, but you don't know if there's more than one point of contact in that receptive field. So you could have 5 points of contact, all in receptive field 1, but as far as your brain is concerned, that's 1 point of contact, because all the brain sees is action potentials from one axon, one neuron. So the size of the receptive field, being a big receptive field, if you have multiple points of contact, the only time your brain is going to know about multiple points of contact is when one point hits one neuron's receptive field and the other hits the second neuron's receptive field. So we played around with that in lab, and you had these little calipers that you could set at millimeters to about an inch, inch and a quarter apart. You could dial it out. So at 2 millimeters, you touch the finger, the person's eyes are closed, they say, yeah, 2 points of contact. You go to the back here, and you put those 2 points down, 1 point of contact. Dial it out to a quarter inch, 1 point of contact. Dial it out to half an inch, 1 point of contact, dial it out to an inch, and then you might hit 2 receptive fields, and they'll say 2 points of contact. So you could have multiple receptors, each linked to the dendritic branch, but if they're all feeding into one neuron, then the brain sees 1 point of contact. The receptors can also adapt to the stimulus, and they also are set up, they're designed to respond differently to stimulus. So a phasic and a tonic receptor. We talked about that earlier when we talked about neurons. The phasic receptor has an on-off response. So when the stimulus is turned on, the action potentials fire, then nothing, then when you turn it off, they fire again. So you have the on, because this is when the stimulus is turned on, and then when the stimulus is turned off, you get a second bunch of action potentials. You could also have what is called a tonic receptor. Somehow I've got all greens today. Great. So a tonic receptor, you have an on response, and over time the action potential level would go down, but it would still be there until the stimulus is turned off. So this would be tonic. So over time, that's what tonic means. You have a general adaptation of the receptor to the stimulus, so it's sending fewer action potentials, but still producing action potentials until the stimulus is turned off. The phasic receptor that's seen here responds when the stimulus is turned off, and then responds when the stimulus is turned off. So phasic receptors are said to be fast adapting. So you turn on the stimulus, they fire, and then they adapt to the stimulus right away, send no further action potentials until you turn the stimulus off. Tonic receptors are referred to as slow adapting. They slowly produce fewer and fewer action potentials, but they're still firing action potentials. So adaptation accounts for some of your desensitization to certain stimuli. When you sit down in your chair, phasic receptors fire. They're pressure receptors. They say, okay, you got into your seat, and then as soon as you're comfortable in your seat and not squirming around anymore, they cease firing, and you can ignore that stimulus. So that's in the back of your mind. You're seated, don't have to focus on it. And only when other things are telling you have to move around, then you're aware again of the pressure of the chair. So central adaptation is part of that. The brain says, okay, you're seated, you're safe, I don't have to pay attention to that anymore. So the brain ceases, it just sends inhibitory input down to cut off those afferent pathways. You don't focus on it until the position changes again. This central adaptation is restricting the amount of information that's going to the cerebral cortex, but that is a good thing, because if you were focused all the time on the pressure of the chair on your body, you wouldn't be focusing on what's going on in lecture. You wouldn't be able to write any words down because you'd be so focused on this pressure of the chair which occurs first, and all these other inputs would be secondary to that. And so any kind of coordinated effort to function in class would cease. Baroreceptors are mechanoreceptors, but special kinds of mechanoreceptors that are there to sense stretch of tissues in your body. So we'll talk about those next semester with the cardiovascular and respiratory and digestive system and renal system. So carotid sinus and aortic sinus, those are pressure receptors for blood pressure, and they'll influence back. If the blood pressure goes down, then the cardiovascular center will get stimulated and the heart rate will go up and contractility will go up. So blood pressure is back to normal. When the respiratory system, when the blood is sensed at the carotid bodies, then at the other branch of the carotid artery, or actually between the two branches, when the blood CO2 levels are high, then you fire the nerves to the respiratory centers to tell the lungs increase ventilation, so you blow out more CO2. So these kind of interact together. The carotid and aortic sinuses are sensing blood pressure, but the carotid and aortic bodies will be looking at the CO2 concentrations. We have stretch receptors in the lungs, but they only really function at the extremes of inhalation. So if you inhale too much air, which is really hard to do, but in some conditions we are under either disease process control or medication process control, inhalation can become excessive. So the stretch receptors at that point, they will fire, and you'll turn off the stimulation of the inspiratory muscle, and you actually exhale more air than normal. So it's forced expiration beyond just a normal expiration. So protective reflex, so that the next time you inhale too much, you're starting at a lower volume, you'll be more within the normal range, hopefully, and the receptors won't have to respond the second time. Baroreceptors in the colon, you're probably only aware of that when you have excess gas down there, or maybe if you have an obstruction, then you might feel the pressure there, but usually it's a buildup of gas that makes you aware of pressure in the colon. You're aware of pressure in the rectum, because that's behind the bladder, because those stretch receptors will relax your internal anal sphincter, and that tells your brain, oops, you gotta find a toilet really fast or you're gonna poop in your pants. So you learn to constrict the external anal sphincter if that's under your conscious control, if you don't have a toilet available. The bladder receptors, you can, under the influence of your sympathetic nervous system, store a lot of urine. If you're exercising, your bladder will get less urine given to it or delivered to it, but also the muscles will relax, so the stretch receptors are less sensitive, so you don't have this urge that you have to go to the bathroom. But under normal situations, you get around 250 ml, 300 ml of urine there, and then you get a signal to your brain that you're going to evacuate the bladder, and so you again either contract the muscles that constrict the urethra or you void the urethra. So more about that next semester. Small intestine also has baroreceptors. You're probably totally unaware of those at any time yet.
Do your baroreceptors have anything to do with the hiccup?
That's usually, they think, a diaphragm spasm. And so your diaphragm is moving and causing air to come in and out. So that hiccuping, the diaphragmatic spasm. So, no, I don't think so. It could be that I'm not aware of it. Cover all bases. No, but I could be unaware of it. Okay. Chemoreceptors, you have chemoreceptors for taste, you have chemoreceptors for smell, but in the other organs, you have chemoreceptors in your aortic bodies that will tell you about CO2 mostly. O2, your chemoreceptors really don't pay attention to O2 until the PO2 is less than 60 millimeters of mercury. So your PO2 has to be less than 60 millimeters mercury, and it's usually somewhere between 100 and 75, well actually 140, no, sorry, I'm getting my PO2s at the cell, yeah, 140, but, okay, so at the tissues, it can be this low. Tissues. At the alveoli, it's 100 millimeters mercury, or 150 with a blood. At the alveoli, be 100. Your alveolar pressure will be 150. So the blood that's coming out of your left heart that hits your aortic bodies is going to be 100 millimeters mercury partial pressure. And by the time it gets to the carotid bodies, it really hasn't gone to many tissues, so it's going to be very close to 100 millimeters of mercury at the carotid bodies. So usually you're not getting down to 60 millimeters of mercury partial pressure, except at the tissues, where you're actively dumping O2 and picking up the CO2. And all that low PO2 does out there is vasodilate, so you get more blood delivered to the tissue. There's no chemoreceptors out there, no effect on your respiratory system with the tissue PO2 below 60. If the PO2 at the aorta is 60, if the PO2 at your carotid bodies is 60, then your brain is going to pay attention to that and do something about it. In the meantime, it's going to pay attention to CO2 and hydrogen ion. So pH and hydrogen ion. And how is that done? It's done centrally by chemoreceptors that are paying attention to hydrogen ion, but there's carbonic anhydrase in the cerebrospinal fluid, so CO2 that comes in is converted to hydrogen ion, and then the chemoreceptors respond to that. The aortic bodies and carotid bodies, they're going to respond first to CO2 and somewhat to hydrogen ion, but primarily CO2. Trigger cranial nerve 9 from the carotid body and cranial nerve 10 from the aortic body. That will directly stimulate the cardiovascular center to tell the heart to beat a little faster, get more blood out to the lungs, and then the cardiovascular center tells the respiratory center increase respiratory rate, so you get more blood to the lungs, more exchange with the room air, and more CO2 gotten rid of. If your CO2 goes down, then the brainstem says, don't need to pump so much blood to the lungs, and the respiratory rate should go down so we can conserve CO2. We don't want to be losing CO2, we want to conserve it. So let's take the blood away from the lungs, send less blood to the lungs, and then decrease the respiratory rate so there's less exchange with the room air. More CO2 stays in the blood, and CO2 levels go back up. Olfactory nerve 1 is a chemoreceptor, very interesting chemoreceptor. It's got these long bipolar neurons, and at one side they've got these long branching, looks like dendrites, but they're actually microvilli. And they call them cilia, but they're really microvilli. and those have binding sites on them for different odorants that are in the air. And the chemicals, well, the cilia are embedded in mucus, but the chemicals that you're breathing in actually get combined with water molecules and diffuse in with the water around the mucus to get to the binding sites on the odorant receptors. So the water-soluble odorants actually have an easier time getting sensed than the lipid-soluble odorants. It's kind of interesting. The binding of the odorant to the microvilli sets off an action potential in bipolar neurons. Those are the ones that are stuck in your cribriform plate. When you pull the brain out of the skull, you lose all your olfactory neurons. So they're all broken off and stuck in the nasal cavity and the cribriform plate. So what you see when you remove the brain is the optic bulb and the optic tract. The gland here is what's secreting the mucus that's going to cover the cilia. It's called Bowman's gland. It has nothing to do with Bowman's capsule in the kidney and Langerhans, and those guys' names got stuck everywhere. Somebody came in and asked me, are the Purkinje fibers that you're, the Purkinje cells that you're talking about in the cerebellum the same as Purkinje fibers in the heart? Nope, totally different. So unfortunately, the eponyms are still around, but call it an olfactory gland. That's a preferred description. Also stem cells here. The bipolar neurons are constantly being replaced. And the turnover, the half-life, I believe is a month or a month and a half. Every month and a half you replace your bipolar neurons. If you have a head injury, say my mom fell into the tub and whacked the back of her head, so she had her brain shifting inside her skull. What ended up happening is all these little olfactory axons got sheared off because the brain moved forward and back, and then the olfactory bulb moved forward and back, and all these little tethered neurons just got snapped off. So she lost her sense of smell for quite a while. Slowly it came back as these neurons were regenerated, and I believe she got full sense of smell back, although her taste habits changed a lot. She didn't taste things as well anymore, since taste and smell are very closely linked. She may not have gotten full sensation of smell back, but enough to be safe and functioning. We don't have gas at home anyway, so that was okay. She didn't have that many things to seek out with smell as danger. The support cells, physical support as well as nutritional support to the bipolar neurons. The gustatory sense is the sense of taste. Now there's a new bunch of people who say there are no particular locations for sweet, sour, and salty. Okay, well then I must be very abnormal, and a lot of my friends must be very abnormal, because I sense sweet best at the front of the tongue, and I sense sour and salty best on the sides of the tongue, and definitely bitter is in the back. So if you played around with that in lab, you know that that is true, that there are higher concentrations for those taste dents in certain locations. The circumvallate papilla, the taste buds down there have the highest concentration for bitter receptors. The bitter, the quinine that you use in lab, when you apply it to the tongue, initially you taste nothing, and then a few seconds later, all of a sudden you have gag response. The application of the bitter quinine to the surface of the tongue, it's going to take a while for that saliva to percolate down into these crevices to get to the taste buds. So there's a delayed taste for bitter. Bitter also is sensed on the epiglottis and also sensed in the back of the mouth to trigger that gag response. Because most bitter things that you put into your mouth are bitter because they're spoiled food and you better not eat them. So the gag response is a protective way of getting that stuff out. So the things that you've learned over time, they're bitter, like coffee, you get used to it. So probably the first time you tasted coffee, you probably got a gag response. And then somebody says, oh, but it's good. Yeah, try it again. So you try it again, okay, they say it's good. You keep trying it, and pretty soon you override the gag response, and then you start appreciating the bitter flavor, maybe, or you go back to water. Fungiform papilla have taste buds on them as well. Those will have higher concentrations for sweet, sour, and salty. And the filiform tend to have no taste buds on them. They're there for grooming purposes. So cats use their filiform papilla to groom their hair. They're also used in helping to abrade the food that you're trying to chew. They help to rip the surface of the cells apart. So they're helping with digestion. Wherever the taste buds are, they're all over the oral cavity, even down into the pharynx. But the higher concentrations for sweet tend to be in the front, sour and salty on the side, and bitter in the back. So umami is just a term the Japanese developed to mean very flavorful. When they invented Ajinomoto, then they started talking about this flavor enhancement, this wonderful mineral-related type of flavor enhancement, and they called that sensation umami. Now Ajinomoto has a bad rap because it gives a lot of people headaches, it binds to other receptors and causes problems in the head. So the chefs are using natural umamis from the meats and other protein sources, which give you this mineral content, this sensation of umami. There also is another receptor that they talk about for water. You have a water flavor receptor, and you think water doesn't have flavor, but you think about it, water does have flavor. And Maui actually has a contest for the best tasting water, and places all over the world compete on Maui for best tasting water. Hawaii used to win. I don't know if Hawaii still wins now. So gustatory sensations are going to travel for sweet, sour, and salty. Those are traveling via cranial nerve 7. That is a 50-50, the both kind of nerve. So facial expression, but also taste for sweet, sour, and salty comes from the front of the tongue and a little bit in the rest of the oral cavity. The bitter flavor receptors are in the back and also in the oral pharynx, and that is carried by the glossopharyngeal nerve. And then vagus also in the pharynx and on the epiglottis, and that it will be responding a lot to bitter, and again, for gag responses. All of this information goes to the nucleus solitarius, and that's in the junction between the pons and the medulla. Then it goes up to your thalamus and out to your gustatory center, which is in the insula and also shared partly by the upper part of the parietal lobe here. The hearing, you can hear if you put a vibrating tuning fork on the bone will conduct sound to your cochlea, and you can hear the sound. But since bone is dense, the sound waves diminish and you cease to hear the tone of the vibrating tuning fork, but it's still vibrating. So you move that tuning fork to the external auditory meatus, and the vibrations going through the external acoustic meatus to the tympanic membrane, and the ossicles are set in motion, then you amplify the sound again. So even though you couldn't hear through the bone, you bring it to your ear canal, oh, the sound is back. And it's quite audible. It's not faint, it's quite audible. And that's due to this first line of amplification, due to the vibration of the ossicles. And then there's a second amplification that's occurring when the stapes presses inwards and compresses the fluid in the vestibule. And then those waveforms go out, and wherever they can set the basilar membrane in motion, then the receptor cells will be activated. The tympanic membrane, that's your main eardrum, but you have a secondary tympanic membrane as well, and that's located at the round window. So this secondary tympanic membrane at the round window gives this name to the duct, the tympanic duct. So if we look at the ducts out, I don't have a picture of it. Oh, it must be coming up. Okay, here. We've got a tympanic duct that is going to the round window, and then we have a vestibular duct that's going to the oval window. So we come back to this picture here. The oval window where the stapes is pressing in and out, it's going to compress fluids in the vestibule, and those vibrations are going to go into the vestibular duct. Then the dissipation of the vibrations, meaning how do you get rid of them so that they don't start reverberating back and forth, up and down this cochlea and causing confusion in what you're hearing. The vibrations then dissipate at the round window through the vestibular duct. When you want to equilibrate pressure to the middle ear, yawn, open your mouth wide or swallow, then the tensor belly palatini is going to pull on the tissue right here, and you'll pop open this auditory tube temporarily, and air will go up to your middle ear. You also can pop it open when you're blowing your nose really hard. But if you have bacteria in the back of your throat while you're blowing your nose really hard, you pop that auditory tube open, these little bacteria, they just grab a hold of the epithelial cells in your eustachian tube, and as soon as they get a foothold, doesn't matter if that tube closes down, they can migrate through a closed tube all the way up into your middle ear, and you get a middle ear infection. So be careful when you have a sore throat, you have an infection in your nose or in your throat, about blowing your nose really hard and popping those eustachian, those auditory tubes open. So first ossicle is your malleus. It looks like a mallet. Looks like a little hammer. And then the next one looks like an anvil that a blacksmith would use, and that is incus in Latin. And the next one looks like a stirrup for a horse's saddle, so it's called stapes. There are nerves that go to the malleus, there are nerves that go to the tympanic membrane to the malleus, and then another nerve that's going to go to the muscle that controls the stapes. When the sound is getting louder and louder, these nerves start to fire. The tensor tympani muscle is controlled by cranial nerve 5. When that muscle contracts, it prevents the malleus from transferring vibrations to the incus, so less amplification of sound. And then the stapedius muscle, controlled by a facial nerve, when it contracts, then the stapes is inhibited. So usually both of these are firing at the same time. So malleus doesn't transfer vibrations to the incus, and any vibration that's going through the incus is not going to be able to set the stapes in motion very easily. So you've got two inhibitions of this amplification, first line of amplification. If you get an infection in the middle ear, you get bone deposited in these ligaments, and also bone deposited in the attachments between the ossicles, and they freeze up, and they don't transmit sound through the middle ear anymore. So you have just lost the ability to hear sounds through your external auditory natives. So you have to implant something into the ear that will come in contact with the bone and transmit sounds that it picks up from out here through the bone to your cochlea. So hearing aids, the old hearing aids used to sit on the back of the ear and transmit sound through the mastoid process to the cochlea. Now they've gotten them small enough they can insert into the ear canal, pretty much be invisible. You're looking at somebody from the front, you don't see it. You look at them from the side and you see, something beigey in their ear canal, and it's a hearing aid. The inner ear has vestibular apparatus and your cochlea. They're continuous with each other in that there are membranous channels that contain this endolymph. And think of that endolymph as intracellular fluid. So you've got membrane. So think of that as your plasma membrane. The fluid in here is going to be high in potassium. And this will be your endo. So inside. It's all one word, but I'm just going to hyphenate it. So inside. And this is perilymph. So around. Think of this as extracellular fluid, ECF, or ISF, interstitial fluid. This is going to be high in sodium. High in sodium, low in potassium, high in potassium, low in sodium, just like the cell. The endolymph will be what is going to help you hear and transmit sounds. The sensors in your vestibular complex, the ones that are getting distorted by fluid, that due to the bones moving and the fluid lagging behind, the fluid that's distorting those receptors is also going to be endolymph. This perilymph is sort of a support of the areas that are critical for the health, well-being, and function of your receptor. You've got a membranous labyrinth that will contain endolymph. So this line here, this will be your membrane. Right outside of that is going to be the high sodium perilymph. And then there's going to be periosteum and bone. So perilymph, periosteum, and bone. You can think of it that way as well. Endolymph inside these critical channels. Inside the channels that will sense rotational movement Rotational movement will be sensed by your semicircular canals. Linear motion isn't going to cause the fluid to move in these channels. You have to have an angular motion, and it has to be in alignment with a particular semicircular canal to set the fluid in motion. So your anterior semicircular canal tends to be oriented forward and back. So tumbling forward, you're going to set that off. The posterior canal. The posterior canal will respond to movements, tilting your head side to side, and then shaking your head side to side is going to be stimulating the lateral semicircular canals. So your brain learns to interpret information coming from the anterior canal as meaning the head or the body is going in the direction of saying yes, so maybe tumbling forward. There's going to be some stimulation of the anterior, but not the lateral or the posterior canal. And then if you're Cirque du Soleil and you're doing cartwheels, then your head moving laterally, the lateral canal will get stimulated. Your posterior canal will be stimulated. And then if you're spinning around or shaking your head, no, then the lateral canals will get stimulated. The other canals will be relatively silent. Your brain learns to put the puzzles together and determine what direction your body's moving. Eyes are very powerful stimuli, have very powerful ability to override those semicircular canal stimuli. So if you start to learn how to tumble, start to learn how to turn in dance, usually the movement of the fluids in the semicircular canal makes you dizzy. You stop turning and you start wandering around the room all ataxic and looking like you're stroking out or drunk. But as you learn to focus on a spot while you're turning, then your eyes override that input from the semicircular canals and you're no longer dizzy anymore. The linear motions are sensed by utricle and saccule. The orientation of those receptors are either straight up and down or they're horizontal. So when you have a horizontal movement that distorts receptors, the brain interprets that as horizontal, forward and back, or side to side movement. And then when you're going up and down, like on a trampoline or in an elevator, you're going to stimulate the other receptors. So angular motion, semicircular canals, but straight up and down or forward and back, that's utricle and saccule. So utricle and saccule, the orientation of the receptors, they're at spots in the ampullae, in the areas of the utricle and saccule. So maculae is plural macula equals a spot. So it's just a collection of the receptors in a particular area. So macula, they're pointing here both at utricle and saccule. The saccule is going to tell you about movements up and down. The utricle is going to tell you about horizontal movements. So as long as you're going to University of Hawaii, you can use UHM as a mnemonic for utricle horizontal movement. You then remember saccule does what's left, which is vertical movement. So utricle, sensing horizontal movement, UHM, University of Hawaii at Manoa. So you can know what school you're going to, that's your mnemonic.